I think, can you hear me? I've got an attached microphone. Well, welcome everyone to this discussion about compulsory treatment and the Mental Health Act. I'm George Hooper, I'm a psychiatrist, retired, but carry on doing academic things, and I have a long-standing interest in coercion and mental health law and mental health law reform. Just by introduction, just a few things about the Mental Health Act and compulsory conditions. Some very troubling statistics that have bothered me for a long time and become very prominent in the course of the recent independent panel review of the Mental Health Act. There's been a striking increase, a stunning increase in the number of involuntary detentions, around almost 50% in England in the 10 years between 2006 and 2016. Other countries in Europe have had an increase, but other countries have been fairly stable over that time, and some have actually had a decrease. The other very concerning aspect is the disproportionate representation of people from black and minority ethnic groups amongst those who are detained and those who are detained in progressively greater security. Also, quite astonishing is the huge, absolutely huge variation in the rate of detentions, involuntary detentions, across European countries. 20-fold between Italy, the lowest, and Austria, the highest, in the most recent study. But in 2004, there was another study which showed a 30-fold difference between the rate in Portugal, which was the lowest, and Finland, the highest. So stunning variation across countries. It's troubling. So there's now general agreement that the reform of the Mental Health Act is required, including changes that would promise a reduction in the number of compulsory detentions. Many, myself included, would say that the Mental Health Act is well past its sell-by date. In fact, in its fundamentals, in its paternalistic fundamentals, it hasn't really changed in the last 200 years. Unlike the Mental Capacity Act, patient autonomy or self-determination or patient choice is not accorded anything like the same respect. The review of the Mental Health Act does recognise this difficulty about the lack of respect for persons' autonomy or self-determination. It makes a number of recommendations that attempt to deal with this. Many people, or quite a number of people here, will believe that they haven't gone far enough in strengthening the patient's self-determination, autonomy, or right to refuse treatment or to make choices. But we'll see how the discussion goes this evening to see how people have responded to the independent panel report. Now, the way we're going to run this is I'm going to do a brief introduction of the panelists in turn. It's a very, very strong panel, as you'll see, covering, I think, all of the areas that are appropriate to cover. And then I'm going to ask a question, a pre-prepared question they have in mind, but they're not allowed to speak for more than 3 minutes in responding to the question, and no PowerPoint, it's just speech. So I'll introduce them, and then after the panelists have responded to the questions asked, then we'll open it up to the audience for comments and questions. We're going to go for about an hour and a quarter altogether. Okay, so the first panelist is Steve Gilbert. He's a serious mental illness living experience consultant. He's from the West Midlands. He's had extensive personal experience of mental illness and has been sectioned, I think, in the past. He was appointed as Vice Chair for the Independent Mental Health Act Review. He's also a trustee for National Mind and the Association of Mental Health Providers. He's co-produced an engagement model as part of the Time to Change anti-stigma program, which we'll be hearing about later, that aims to improve the outcomes of young African Caribbean men with mental health problems who come into contact He's also the West Midlands Service User Representative and Executive Committee member of the Royal College of Psychiatrists, and is working with the National Collaborating Centre to develop the Patient and Carer Race Equality Framework, which is mentioned in the review. He's no stranger to media work, speaks many events, issues related to mental health issues. And just finally to say, to really quote what another panellist, Alex Rapp-Keane, has said about Steve and his work with the mental health review. He says, Steve's commitment, passion and hard-earned knowledge infused the working group meetings, and his robust but unflaggingly polite challenge of received wisdoms were instrumental in sharpening recommendations. He's a true force for good. Steve.
Can you use the handheld microphones, please?
Can indeed. Thank you very much. I'm going to steal this and say that I've got the toughest question. So there.
Oh, sorry, yes, I didn't mention the question.
Shall I mention it? Yes. So the question that I was given was, how far can reform of the Mental Health Act be expected to reduce detentions? What is the most important? For achieving this from my perspective? So the first thing is that there's no quick fix, and this really requires a long-term commitment. In the review, we created a plan. That's basically all it is, and now it needs to be followed through. The report highlighted that there was no clear single driver to the increase in the rate of detention, so it's fair to say that there is no simple solution to addressing them. And from the point that somebody would meet the criteria to be detained under the Mental Health Act, it's fair to say that a lot of things have gone wrong prior to that, both immediately before and a long time before that. And surprise, surprise, things like quality of housing, employment, the strength of the local voluntary sector, your personal relationships, how we are supporting people who have a mental illness to manage their illnesses, are we paying attention to known triggers, debt management, all of these things and more are things that if we can get right will help to reduce, and if we don't address, we will continue to go round and round as we are. I'm going to say this first as well, we need more research. So from the point of view of the review, we really did try to find different models that we felt were viable alternatives to detention. We found lots of examples of things that were quite good when somebody was in a suicidal crisis, but not so much in terms of somebody being in an acute psychosis. When we think about research, it's not just doing the same old research that we've done before. It has to be user-led. It has to really reflect the experiences that people have had, and it really needs to focus on the social factors that can lead to crisis. And we need to be thinking about the variety of options. One of the things that came out really strongly, both in terms of being detained, that there was not really much choice around that, but certainly when somebody is in a period of time before being detained, that there weren't really many alternatives, so we need to think about how we do that. Of course, I need to say that we need to have good quality access to statutory services. As somebody who has been living with a mental illness for the last 10 years, I'm still a user of statutory services. They have their place, but also having access to a full range of other services is really, really key. Mark will shout at me if I don't mention social care and that integrated approach. And really, this today is a call to action. As I said, we've created this really fancy plan. One thing I want to mention is that in the report, we, and when I say we, I mean the Service User Carer Group, a group of 12 individuals who have a range of experiences, both kind of skill-wise and of the Mental Health Act. We worked tirelessly throughout and were heavily embedded, and we created a 2-page letter which we sent to the Prime Minister, and in that we referenced the 4 principles: the principle of choice and autonomy, the principle of the use of least restriction, therapeutic benefit, and the person as an individual. Now, in that letter, it's focused on the experience of the Mental Health Act, but actually, when I speak to lots of people who've used or experienced mental health services as a whole, those principles aren't really that well represented there. Actually, there isn't a huge amount of choice. Sometimes you have to question if the things that are put upon you are therapeutic. Stuff like, just take this medication. Do you have much choice about it? Soft coercion from your medical team sometimes. And seeing the person as an individual. So I'm going to shut up by finishing with just one last statement. I think if we are really to reduce detentions, give people what they want, when they need it, how they want it.
Right, thank you very much. Next we have Bryn Lloyd-Evans, Ms. Bryn. He's a senior lecturer in the division of psychiatry here at University College London. He's a social worker by training, and as he's a doctor, a PhD doctor. He's worked in community mental health teams and forensic rehabilitation services. He's collaborated on a number of significant projects in the social sphere, researching social inclusion in mental health, acute day units, crisis resolution, and home treatment teams, peer support and self-management following mental health crisis, and intensive support groups for adults with intellectual disabilities. He's co-led the NIHR-funded Community Navigators Study.
I didn't get the name, sorry.
Oh, Bryn Lloyd-Evans.
Okay, thank you.
Did I not mention his name?
At speed, George. Just keep it
It's a
in place.
complicated Welsh name, after all. So he's co-led the NIHR-funded Community Navigators Study, which is a feasibility trial of the social interventions to reduce loneliness for people with complex depression and anxiety. He's also the Deputy Director of Mental Health Policy Research Unit here. Bryn was a member of the working group for the Independent Review of the Mental Health Act, and also a panel member of the NIHR Research for Patient Benefit Funding Programme. He's played a leading role in the multi-pronged research programme supporting the Mental Health Act review, ensuring its successful completion together with publications in what must be a record quick time. 9 studies, all done within a year, 7 of them already published. I don't think I've never come across anything as extraordinarily productive as that. Brilliant. The question for you is, what do you know about why the rate of detentions in England is rising?
Thanks, George. Hi. Well, the short and the honest answer to that is perhaps that there's not too much we can say with certainty. So this is a really complex issue to which there are almost certainly multiple contributory factors. There are lots of areas where we need better data, and when something is happening at the same time as the rising rate of detentions in England, it's often really hard to tease out whether that's a sort of causal relationship or just something that's happening at the same time. So that's my disclaimer out of the way, but despite that, I think there are some things we can say, and here are 3 things which I think the current evidence suggests are very plausible candidates as contributory factors to why the rates of detentions in England are going up so fast, faster than almost anywhere else in Europe over the last decade. So the first thing is that the Adult Psychiatric Morbidity Survey and other surveys suggest that levels of mental health problems in the general population in England are rising and have been going up over the past 20 years. So possibly the rise of detentions represents the sharp end of that sort of broader phenomenon in the nation's mental health. A second point which seems to be occurring is that there seems to be an increasing stretch on community mental health services, and this is especially apparent in the last decade or last 15 years. So community mental health teams and community mental health services generally are seeing far more people than they ever were. This is not just IAP services, but within secondary mental health services too. The reach of them is they're supporting more people than ever before. But staffing levels and funding levels haven't risen commensurately with that rise in the scope of the services. So in some settings, like community mental health teams, caseloads are rising and the number of contacts being provided to any individual person experiencing mental health problems are falling. So possibly community mental health services are less well equipped than they have been to provide the kind of intensive preventive support needed to keep people well or to avert detentions when somebody has a crisis. And the third factor that seems to be almost certainly contributing to the rise in detentions over the past decade is a change in practice and kind of legal culture about how to support people, a very specific group of people who might need hospital admission, who are not actively objecting to going into hospital, but lack the sort of decision-making capacity to make an informed choice. So 15 years ago, people in that situation would very typically have been encouraged, persuaded, cajoled to go into hospital informally. That very rarely happens now and shouldn't happen according to case law, and people will much more typically be detained formally under the Mental Health Act. Now, whether replacing a kind of soft coercion with a more overt coercion under a legal framework is a good thing or a problem, I think is not a question with a necessarily easy answer that we might come back to. So there are three issues. Beyond that, there are an awful lot more factors that may well be contributing to the rising rate of detentions, but for which I think we lack the kind of clear empirical evidence to say with certainty they are the case. But they include, and big ones potentially, are austerity and increasing sort of social deprivation and the pressures that can put on people, specifically people who may be already vulnerable to mental health problems or detention. Risk culture within mental health services, and the proposed explanation that people have become more risk averse and more concerned with sort of safety within mental health care. And changing patterns in drug use and the availability and the types of drugs available, especially within the mental health population. So just to finish off, one note of caution I'd like to sort of flag up when we're thinking about possible explanations for the rising rate of detention. So one thing that's often mentioned is that it would help to reduce detentions if we could only improve crisis care and have more crisis alternatives. Well, there are lots of good reasons for wanting to improve mental health crisis care, but I think we just need to be a bit cautious about assuming that that is going to sort of solve any problems of rising rates. So there's no crisis service model that has clear evidence of being effective in reducing detentions. And we should note that the sort of rising rate of detentions over the last 30 years has happened in the context of a big expansion of crisis alternatives rather than a contraction. So it is possible, I think it's almost certain, that more upstream interventions are needed as well, and they may be more important than crisis care in actually stemming the tide of rising rates, and that might involve advanced statements or intensive community care. Thank you.
Next, I'd like to introduce Shubhalati, or Lati Smith. She's a consultant psychiatrist at the South London Maudsley NHS Foundation Trust. After running a busy general ward and a community mental health team in Brixton for 5 years, she went on to run the psychiatric intensive care unit at the Maudsley, and since 2010 the forensic psychiatric intensive care unit. She's also a senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience at KCL, and has done a lot of important research on psychopharmacology and especially on enhancing the physical well-being of patients with serious mental illness. She's also clinical director of the National Collaborating Centre at the Royal College of Psychiatrists, and is providing medical leadership for the team developing mental health guidelines, in particular aimed at reducing health inequalities in mental health. She sat on the core working group of the Independent Mental Health Act Review. She was lead for the Criminal Justice System Topic Group, and amongst other roles, also the Deputy Chair of the Mental Health Act Review African and Caribbean Working Group. Lati has always been very finely attuned to the socio-political context of psychiatry. There's a very illuminating interview with her, available online, in which she discussed common perceptions held by many people from black and minority ethnic communities of their relationship to citizenship and belonging in society. It's absolutely well worth reading. I recommend it strongly. Lati, your question is, what can be done to reduce the overrepresentation of people from BME groups amongst those detained?
Okay, so for those of you who aren't aware, I'm just going to quickly remind you that there are profound inequalities in mental health care if you are black, Asian, or from some kind of other ethnic minority, but in particular if you're from a black, African, or Caribbean background. And what that means is that you're 4 times more likely to be detained under the Mental Health Act, you're much more likely to turn up to services in crisis, you're much more likely to be brought in by the police, or brought in by A&E, and you are much more likely to end up in a locked care, secure care and forensic services. Now, this isn't a new happening. This is something that's actually well known. It's been known for the last 35, 40 years. And the problem is that nothing has changed. And it's often said, oh, it's just because black people have more psychosis. Now, in England and Wales, there are about 650,000, maybe 700,000 people with psychosis at any point in time. Of those people, even if 75% of people who were detained had psychosis, that would mean there would still be, there are about 55,000 people a year detained under section. So it would mean that even if they all had psychosis, there'd still be 600,000 people walking around with psychosis. Having psychosis is not enough reason to be detained in the Mental Health Act. It's not a good enough reason. Yet that is one of many reasons put forward as to why black people are disproportionately detained. Recently, there's a study done by Phoebe Barnett from UCL, and it's in Lancet Psychiatry, and what that looked at was rates of detention under the Mental Health Act of different ethnic minority groups. The interesting thing about that paper, and I would urge you to read it, I have to admit that I was one of the authors, but I would urge you to read it, is the explanations that were put forward about, it was a systematic review, all the different research papers, all said various explanations for why there was this disproportionate rate of detention in black people. What was interesting is that less than half of those papers actually based their explanations on any evidence. So it was poor evidence or no evidence. And yet these same reasons are propagated again and again and again. And what a surprise, 35, 40 years later, we're in no better place. So what we did in the Mental Health Act was this. We said, enough of that. We haven't got time to try and work out the reasons why. But what we need to do is think about how we can change this. What we know is that there are a number of factors that increase the risk of people developing mental health problems, and they are things like coming from a very impoverished background, trauma, abuse, all those things. I can tell you as a forensic psychiatrist that when I meet my patients, doesn't matter where they're from, doesn't matter what their ethnicity is, they have often had awful things happen to them in their early lives. Every single one of them, whether they're from Afghanistan, whether they're from Lambeth, whether they're black or white. So, what was striking about that is that, for some reason, those other factors, the trauma, the difficulties, the early life difficulties, the adverse childhood experiences, they are not thought about in terms of black people. Yet, if you're black in Britain, you are far more likely to be at risk of those socio-economic difficulties that increase the likelihood of you developing mental health problems in the future. So what did we do? We said, okay, what can we put in place, what can we recommend that will help to change things in the future? First thing, some kind of framework that changes the way that institutions work with people from ethnic minority groups. And we suggested a patient and carer race equality framework. And what that is, it's a method, a process by which an institution, such as a mental health hospital or a mental health trust, has to work with the local community to find out what their needs are, so that people will use the service and access the service at a much earlier stage. Cultural advocacy, absolutely key. We know that if you can help someone negotiate a system, then that person is going to do better in that system. And in order to do that, it has to be a kind of advocacy that works for them. We have to make sure that the research that's being done is not in some way structurally biased. A lot of the research that we looked at in that paper was unfortunately structurally biased. The researchers didn't know that. They were completely unconscious of the bias that existed. And the problem is that within research and probably within clinical service, there is ongoing institutional bias, implicit bias that needs to be in some way dismantled. And you can't do that by just saying to somebody, stop being racist. That's not how it works. This is not a conscious thing. We need to do something about the workforce. Representation in workforce of black and Asian and minority ethnic people is poor, certainly at the higher levels, and in particular in those professional services that provide therapeutic care, occupational health, and in particular psychology. We also need to think about data, the data that we collect and how we collect it and how we use it. And finally, what we need to do is to really focus on adverse childhood experiences. All those boys, black boys who are suspended and expelled and excluded from school before in primary school and secondary school, they are people that we should be looking at right now, because they are people who are going to grow up and end up having very severe life outcomes, either in mental health or in the criminal justice system, or both. So, what we need to do is focus on the structural factors that are embedded in our services and try and do something about those to make a long-term difference. Thank you.
Thank you.
Can you make sure you speak to the microphone? People saying that they can't hear you on the live feed.
Okay, I'll hold it. Is that better? Okay, next we have Mark Truitt. Mark, also trained as a mental health social worker at Detention, and as an approved social worker under the Mental Health Act. He's worked in community mental health services and forensic services and in supportive housing. He's the mental health social work lead at the Department of Health and Social Care and an advisor on social care to the adult mental health team at MHQT. He was on the working group of the Mental Health Act review. He's involved in workforce development for mental health social work and developing recognition for the role of local authorities in social care in mental health services. He concluded a recent article he wrote on the Mental Health Act review entitled "A Mental Health Act for Our Time," which I think is interesting. He says, "Projects like this are always a compromise between ambition and reality. I hope at least we've provided the government with a realistic basis for modernising the outdated Mental Health Act. If we deliver a framework that recognises the humanity, complexity and diversity of our growing population, we can deliver better mental health services for all."
Thank you very much.
Now, your question, Mark, before I forget. Just make sure it's tallies with the one that you have there. How can local authorities and social care contribute to reducing the need for detention?
It's too late if it doesn't tally. Right, well, thank you very much. It's lovely to be here. I want to use this opportunity, obviously, to talk about local authorities and social work, because that's what I've been asked to do. But I also want to talk about positive and radical changes that we might be able to make. Because I think often we end up talking about things in a way that's very negative, and we need to have hope. Hope is really important. So as part of this discussion, I'm not going to talk about the Mental Health Act very much, because in talking about prevention and the role of social care, I want to go back from the role of detention and the Mental Health Act to the community, and to the idea of prevention, to the idea of the care and support that we require prior to a mental health crisis. That we need services that are accessible, flexible, creative and responsive, and most of all, kind. And that's one of the things that we've got feedback from people who use the mental health services, that they often didn't think they were very kind, and they didn't feel looked after by them. So that's one of the important things we need to change. Most people who experience mental health crisis or have been detained in hospital have that experience for quite a short part of their lives. For most of their lives, they live in communities. They live in homes, they live with families, neighbours, they engage with religious establishments, shops, pubs, centres of leisure, places of work. They need and lead normal lives. And the job of social work and local authorities is to help people to do that. This is where we need the opportunity to hand power and control back to communities. And we often talk about, in mental health, how can we engage with black and minority ethnic people? How can we get black and minority people to use our services? It's the wrong question. The question should be, how can we hand power over to communities to design the services that they need? It surprises me how much the media and the government and other agencies often think of mental health as being an NHS thing, which of course it is, but it's also a social care and local authority thing. And often you find that the statutory responsibilities and the rights for personalised care, for the Care Act, for the Mental Capacity Act, for integrated care planning, for Section 117 aftercare, for the right to housing and employment support, sit underneath local authorities. And of course you also have statutory AMP services, which is one way in which we can use the least restrictive principle of the Act to stop people from coming into hospital. So, Mental ill health is linked to the social determinants of society, as we've already heard. It's linked to power, control, inequality, discrimination, poor housing, poverty and austerity. So we need people who are trained in community support to work within communities to try and reduce those things. This means we need a fundamental redesign of mental health services. We need to transfer resources to a positive community alternative, centred on supporting people within their community and giving people services that they can use to create their own health and well-being. This new way of working is happening in local authorities across the country. We call it strength-based or asset-based working. And it's a way of not looking at people as deficit illness models, but looking at people as strong individuals capable of their own recovery at a rate that they feel is appropriate for them. The implementation of the Mental Health Act can support these models. The Green Paper for Social Care, the Green Paper for Prevention, the new Community Mental Health Framework, personalised health budgets and the long-term plan, these are all examples of asset-based working that we can use to change society. So my vision is for a mental health service in which health, social care, the police and the VCS are working together as integrated equals with the person at the centre and within people's communities, so that we can provide a whole system approach and serve people appropriately based on a model of co-production. This means the government has to change, and we have to have the courage to implement the Mental Health Act as part of a wider strategy where we step out of our silos and work together on behalf of communities.
Next, introducing Alex Rakeen. Alex is a very eminent barrister. His practice is focused on mental capacity and mental health law. He's provided specialist advice and representation up to the level of the Supreme Court and the European Court of Human Rights. Some very famous cases, Aintree and Munchos, amongst them. He's also the creator of the Mental Capacity Law and Policy website, providing lucidly argued commentary on difficult mental capacity issues. He writes extensively, indeed extremely extensively, editing, writing and contributing to leading textbooks, and amongst many other publications, the 39 Essex Chambers Mental Capacity Law Report, referred to by many solicitors as the Bible for those working in the area. Furthermore, he's also a Wellcome Research Fellow and visiting senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience, and a research affiliate at the Essex Autonomy Project, University of Essex. Furthermore, throughout 2018, he was a legal advisor to the Independent Review of the Mental Health Act, and he spent a great deal of 2016 on secondment to the Law Commission as a consultant to the Mental Capacity and Deprivation of Liberty program. It hasn't quite turned out the way he thought it would. Despite all of that, he finds the time to respond the same day or latest the next to my many emails asking questions of a very naive nature about mental health law. Alex, your question, if you have the time to answer it. What, in your view, are the most pressing legal issues for making the Mental Health Act legislation work efficiently and fairly?
Brilliant. Well, thank you, George. Thank you very much indeed. And you've usefully used up almost all of my 3 minutes, because I just want to make 3 very short points, so then we can hear Ray, then we can hear Claire, and then we can get to questions. So the 3 short points I want to make are: the government has already actually committed to the single most important thing it could do in relation to the Mental Health Act on its own terms. Because the government, in responding to the Mental Health Act review by saying it will legislate when time permits, I know Brexit, but time does permit every so often to do something else, to advance choice documents, to putting them on a statutory footing, if that is carried through faithfully, will radically change how treatment is thought about, and that in turn will change the basis upon which admission is thought about. So the legal heavy lifting in terms of the Mental Health Act on its own terms, the government has already committed to. Obviously, the fact it's committed to it doesn't mean it's actually going to necessarily make it into law, viz. legal liberty protection safeguards. But that's the first point. The second point is a pressing legal issue, a very narrow pressing legal issue, which I know many people in this room, including behind me and ahead of me, in front of me rather, feel very strongly about, is it possible to have a Mental Health Act, or indeed a Mental Capacity Act, but let's focus on the Mental Health Act for a moment, compatible with our obligations under international law? The short answer to that, I would say, is yes. If you want more detail, go and look at the appendix to the Mental Health Act Review Report, where this was looked at in detail. But I don't want to dwell on that now, because the much more important point, much more important point, and it's a theme which has been actually said by most of the other people who've spoken so far, is the really interesting and important legal point, is what can we do to develop laws and rights for people which mean we don't even need a Mental Health Act. So rights for people to access services in the community. Rights for people to actually enjoy their right under Article 19 CRPD to live in the community. And once one starts to get to that, positive socio-economic rights, i.e. things that cost, that's the point at which one is starting to move towards eliminating the need for a Mental Health Act, which on its own terms is about the regulation of coercive treatment and detention at the end of the day. And I would just flag up, I'm not here to speak on behalf of the review. The one thing I'm almost most proud of in the review is the bit which says tribunals should have a power to direct service provision in some circumstances. There are many, many other bits in the review which are brilliant, but that bit, if that is implemented, that breaks the fourth wall, or breaks the wall between the system under which tribunals aren't allowed to say to statutory services, you need to spend money. Tribunals would be able to say in some circumstances, the reason this person is being detained is because there aren't the adequate services in the community. You need to do something about that. Obviously, that is only affecting the situation post-detention. What we need, ultimately, are rights for people to access services, enforceable rights, before you even get to that point. Right, that's me.
George, can you use a different microphone? Apparently that microphone, people can't hear it on the live feed.
All right.
Sorry.
This one okay?
I don't know, it's people on Twitter saying they just can't hear you, they can't hear everyone else, just not you.
All right.
It's a very unusual situation.
Next, I'd like to introduce Ray Waddingham. And I think the best introduction to Ray is to quote from her own account of herself, in which she's written, I entered the last century in a psychiatric hospital, diagnosed with schizophrenia and with little hope for recovery. Seen as a revolving door patient with a severe and enduring mental illness, I lived my label, not my life. I bought into the idea that schizophrenia and the many other illnesses I was labelled with were lifelong mental illnesses. I accepted that the best I could hope for was to manage my symptoms with lifelong psychiatric medication. Life, I'm glad to say, doesn't always turn out the way you think. She's now a freelance trainer and consultant, a writer, a practitioner, a researcher, speaker and PhD student at the Open University. She is also chair for the English National Hearing Voices Network and vice chair of the UK chapter of the International Society for Psychological and Social Approaches to Psychosis. Still, yes.
Say that 3 times fast.
She's also an open dialogue practitioner and trainer. With Akiko Hart, she's created a very well-received alternative review to the Mental Health Act for the National Hearing Voices Network. And very recently she presented a superb BBC Radio 4 programme, My Name is Rachel, dealing with experiences of sectioning and what may be done to reduce its frequency. So Ray, your question is, are detentions compatible with a human rights-based approach to mental health legislation, and what could replace the current use of detention? Are detentions compatible with the human rights-based approach to mental health legislation? and what could replace the current use of detention?
So this is an easy answer, really, on the face of it. Our current use of detentions in mental health and the Mental Health Act really isn't in line with the Human Rights Act or a rights-based approach to mental health. And for those of you that don't know, the idea of the Human Rights Act is to set out some fundamental rights and freedoms that everyone in the UK is entitled to. Obviously it's based on international law, but it was brought in 1998 for us here in our law. So it's something we all should be benefiting from. But if you're detained under the Mental Health Act, what goes? What do people have the power to suspend? Our right to liberty and security? Gone. Right to respect for your private and family life? Often gone. Freedom of thought, belief and religion? Potentially gone, especially if your so-called delusional beliefs are one of the reasons you've been compulsorily detained. God, that's a big word. Freedom of expression? Gone. If you keep talking about those beliefs, it's really hard to get out of hospital. But it's more complicated than that, so I'm not really naive. I've worked in the NHS as well as outside of it. And I know that human rights are tricky. It's all about weighing up the different conflicting rights and making some decisions about my rights versus your rights. It's complicated. We're thinking about me and other people. But in mental health, there's this amazing get-out clause. It introduces this idea of mental illness as one of the little loopholes that allows us to take away people's rights in certain circumstances under this name of treatment, because it's in our best interests. It's doublespeak. It kind of joins care and coercion together and makes detention the moral thing to do. It makes it really hard to argue against sometimes. Yet, there are protections. The Human Rights Act says that it must be proportionate and it must be necessary. But if you think about what happens when many people are detained, there's a whole load of things beyond those initially obvious human rights that get lost. There can be handcuffing and physical assault, forced medication, sexual assault, physical assault, seclusion, institutional abuse, isolation from the loved ones, degrading treatment, pathologisation of your beliefs, medication that has really long-term effects that aren't fully researched because there's no decent long-term research into medication, being treated like a second-class citizen. We have, according to the CRPD, rights to be free from discrimination. That means that there should be no legal basis to detain us because of a diagnosis of a mental health problem. And given that for some people being detained means they lose their life, they kill themselves because their rights have been taken away, we need to do something about this now. Current law is discriminatory, but if we go to a capacity-based law, things could improve. So what can we do very quickly? Stop messing people up, change society. Invest in decent, culturally appropriate services that people want. Decouple treatment from the biomedical model. Let's look wider. An acknowledgement that there's that the idea of mental illness is contested. It's not a done deal. And that shapes the legal framework in which these decisions are made. We should really think that detention is the last resort, and like others have said, let's avoid using it as much as possible. We should be honest about the effects of medication. And when people come in with a so-called psychosis, maybe just let them sleep for a week and then talk about what they want to do and have a conversation. Don't go in with antipsychotics straight away. And advanced decisions, I feel, should ultimately be respected if they're made when the person has capacity. We need to do some major work, even greater than has been done already, to make sure that happens. In Juliet Herman's words, no intervention that takes power away from the survivor can possibly foster her recovery, no matter how much it appears to be in her immediate best interest. Thank you.
Our final panellist is Claire Henderson. Claire is a senior lecturer in psychiatry at King's College London and a consultant psychiatrist. The broad aim of Claire's research research has been to address the disempowerment of people with mental illness as a result of the illness and ensuing stigma and discrimination. She is an investigator evaluating the effects of stigma at the National Time to Change programme. The studies have looked at attitudes in the general population and particular groups of people with mental health problems. Claire has also evaluated the effectiveness of anti-stigma training programmes for medical students and mental health professionals. This is the first time, actually, that a national mental health anti-stigma programme has been evaluated against a number of targets to reduce discrimination. Claire has also been prominent in the development of advanced statements in the form of joint crisis plans. This is obviously very relevant given the recommendation of the Mental Health Act Review that advanced choice documents be introduced into mental health law. She's been an investigator in 2 of the largest randomised controlled trials of the effectiveness of joint crisis plans on compulsory admissions, and has also examined the experiences of service users in their use. Claire also has relevant international experience. She was previously Associate Director of Evaluation and Health Services Research at the Veterans Health Administration in the United States. Claire, your question. What do advanced statements offer and how can we make them work?
Thank you, George. So, is this the right mic? Okay. So, advanced statements obviously offer people the chance to have a say about their possible future care at a time when they have capacity to do so and can reflect on previous experiences of what worked well, what helped them, and what didn't help them, and what they wouldn't want to have happen again. Now, beyond that, in terms of what they offer, it depends a little bit about how you produce that advanced statement. In the United States, every state has some kind of legislation which can be used to develop an advanced statement, or an advanced directive as it's called there. And you can sit down with witnesses who testify as far as your capacity is concerned, and you can write it out on your own about what you want to have happen or not happen, and send it off to a state registry. And obviously that model provides you with maximum autonomy in terms of the content of that advanced statement. However, without any discussion with the mental health professionals who may be potentially treating you, it's hard to have confidence that what you've put on there is going to be followed. And the joint crisis plan was really a response to that problem. The joint bit in there reflects the fact that, as opposed to a purely kind of autonomy-promoting model, it promotes a model of shared decision-making. So it offers the opportunity for information exchange between the clinicians responsible for treating somebody and the service user. And the exchange part is really crucial. So the service user is essentially, educating the clinicians about what has worked before, what has not worked before, what they would want to happen again, and at what point, they would want involvement from the team. And the clinicians are there to talk about, what they think is feasible, what's clinically doable, if you like, what's in accordance with best practice, and to ensure that no false expectations about what's doable, under existing legislation are raised. So there's got to be an information exchange there, and then what then ends up as the content of the plan is what the service user wants. But if some of it doesn't appear to be feasible, then obviously that has to be added in terms of to make it very clear. So that's the joint crisis plan or shared decision making model. And as I said, they offer slightly different things in terms of autonomy versus a plan that you can be more confident, that the clinicians are signed up to. And in terms of what they then offer, having produced that, I think the clearest thing from research, both here and in the United States, is that process of joint production of an advanced statement offers a way to improve the therapeutic relationship. So people have looked at this both qualitatively and particularly quantitatively using a thing called the Working Alliance Inventory, and it seems like therapeutic relationships are improved by having this open discussion about what should happen in the event of relapse. In the trial that I led on for my PhD, and in one or two other trials, it looks like that they also can offer in certain settings the opportunity to reduce the use of the Mental Health Act, so rates of detention may be lower as a result. Whether that's because of the improvement in therapeutic relationships, that there's more trust and better things happen subsequently, is not very clear. But it does look like, from the meta-analysis that's been done for the Mental Health Act review, that overall there is a possibility of reducing rates of use of the Mental Health Act. In terms of how we can make them work and make sure that they do achieve that, then there are a couple of things that really need to happen. And obviously this is crucial now because, as Alex was saying, this legislation is at some point going to happen. But the legislation is one thing, and then obviously the implementation is something else. So we need some infrastructure to make sure that people can make an advanced statement, whether that's along the sort of autonomy model where they just do it without the clinical team or with the clinical team. I guess legislation will tell us a bit more about what's expected, but I would think we need to offer both of those routes. And for people to create an advanced statement, they need the opportunity to think about this before having that discussion with the clinicians. So people need to be able to reflect, to talk to people that are important to them about their previous experiences and what they might want to have on the plan. So they need a chance ahead of time to think about it before it gets finalised. And then they need the opportunity to revise the plan in light of further experience. So if people get admitted to hospital or have a relapse in their illness again, or further reflection on what's happened before. Sorry, I must wrap up. And the other thing that needs to happen, very crucially, is that clinicians need to accept that they need to get involved with this. There have been trials where there have been problems of implementing things like joint crisis plans because clinicians feel like they haven't got much to offer, I think. They can't do very much about it, that kind of thing. But so clinicians need to get on board. Thank you.
Okay, right, so it's now over to questions, comments. You can address questions to individuals or to the panel as a whole. I'm going to have to point.
Please don't start talking until you've got a microphone, because people on Twitter can't hear anything without a microphone.
I've got a few points and I'll make them very quickly. I hallucinate and hear voices, but I'm not ill. I don't take psychiatric drugs. I'm not sure if all of the panel are familiar with James Davis's book, Cracked, Why Psychiatry Does More Harm Than Good. I personally think that the Mental Health Act should be abolished. It's one of the few areas of law where you can be locked away for something you might do. I think a side issue is to do with there are places in Italy where mental health hospitals have been closed, and I think that should happen in this country. And I'm not a service user, I'm an expert by experience.
Thank you. Does anyone want to comment?
I'll have a little comment. I don't know what you said in terms of it's taking it to a radical direction. Other countries have thought about other ways of doing this, and I think we need to be a bit bolder in thinking what we can do here.
Okay, yes.
Yeah, so there's a discussion about what we need to do, and you earlier talked about, or someone talked about action. What action? What is actually being done? I love your talk, right, and your focus on human rights, because whatever the issue is, whether it's about detention, coercion, the way you're treated in care, whether it's about access to appropriate services, or access and support from the welfare state, whatever it is, our rights aren't being respected. Our basic human rights aren't being respected. And we're not viewed as human. Read our notes. They clearly, the clinicians writing them, clearly don't view us as human. So it comes back to, so for me, the issue is about democracy. It's not about user involvement or co-production. That is just taking the piss. To call it that, it's not being true to what the situation is. We are not part of the demos. We're not seen as full citizens, full human beings within a democratic society. It is that extreme, the violence that we have to deal with of whatever nature. And we're having a discussion about which intervention we need to have. Why are we even competing about whether there should be an end to austerity, better crisis support, culturally relevant services, better advocacy, access, more rights under the Mental Health Act? They all fucking need to be done. And then what, just to stick to the, to the non-service users, the people who are part of democracy, who aren't removed from citizenship, what are you going to do? Because I remember when the Mental Health Act review was being undertaken, and trying to communicate with professionals about, well, can you include demands that we have about our basic human rights in your industrial demands? No, not interested. So there's doctors, there's nurses, there's social workers in this room. What are you actually going to do? Because we've been talking for a very long time. You've been concerned about us for thousands of years. It's never worked out well for us. What the fuck are you going to do?
Thank you. That's a very serious and difficult question.
It's a very serious and difficult issue.
It is, yes.
I'm afraid to say something.
Yep.
So, I think what we have to accept is that we haven't done enough at all, and things are difficult. But what I'm hoping, and I think Mark talked about it, is that the fact that we've been able to do this independent mental health act review means that we are going to be able to make some difference. Fact is that actually all mental health services are not all awful. There are many people who...
No one's said that, no one's made that point.
Well, I think
irrelevant to what's been said.
Yeah, well, I think it isn't irrelevant to what's been said, because I think there's many people who assume, who haven't got any contact with mental health services, that unfortunately mental health services are probably like one flew over the cuckoo's nest, and they're not. So things have improved, and they're continuing to improve over time.
Detention is getting worse. They're getting worse. It's harder to access services. You're more likely to get locked up. They're not getting better. The facts are they're getting worse, as was said at the beginning.
Okay, so I think what we know is that the way in which people are treated by the individuals and clinicians in services is better than it was before. We do have a problem with a lack of resource, and the hope is that as a result of some of the work that we've done with the Mental Health Act Review, that will improve over time. But we aren't there yet, without doubt, but we are working at it, and it is a work in progress, and we've got a better understanding of what is needed now.
Would you take industrial action for it? And if not, why not?
Well, when you say take industrial action, you mean go on strike?
Well, yes.
Nurses
and doctors go on strike for pay rises. Best of luck to them. They won't go on strike for our basic human rights.
I'm not so sure that me going on strike would really help my patients. What I think would really help my patients is me advocating and lobbying.
The doctors do go on strike, so doctors shouldn't go on strike at all.
Well,
because you said you shouldn't go on strike, go on strike for your wages.
That's a different argument.
Yeah.
Okay. Does anyone else want to?
I'm really interested in human rights law, and I know almost nothing about it. But I have this idea that if we could get support from lawyers who could help us take cases forward, then things might change. I know that I'm actually getting some really good care in the mental health system at the moment. They don't agree that I don't agree with my diagnosis, but they're quite nice. But on Twitter, I've heard so many stories since doing the documentary of people that are currently stuck in this cycle, having a hideous time in current treatment with current professionals. It's not the whole of it, but the fact that it's happening is not okay, and we need everyone's help to stand up to that. But like you said, I don't think we can do it on our own, and we need some of that knowledge and wisdom and lawyers that are willing to help us with it.
Steve. One thing that the review absolutely identified is the complexity of this. I get your anger. for mental illness, and 4 members of my family have been sectioned. It has torn my family to bits, so please don't laugh.
No, you get my anger.
I get
you get my anger. Yes, I get your conversation.
And what we need to understand, and what the review showed, is that there isn't one thing and there isn't one experience, even of being detained. And if we'd identified even just one single area that was terrible, we'd go, stop doing it. But even with an area like CTOs, which it's fair to say we're going to completely get rid of, what we found was that for a very small group of people, who actually we kind of were able to really clearly define, they actually were really important, and they were actually life-saving. Are they being overused? Absolutely. And the data says that. The data also says that if you are from a certain minority ethnic background, that you are up to 9 times more likely to be, to have one. So that's clearly wrong. But for some people, they were absolutely crucial. And that is true of detention. And we absolutely need to reduce the rate. But there are situations in my life where I know if I was back in that place, where I was so deeply in love, where I was, sorry, I listened to you. Where I was so deeply unwell that I needed to be detained, and Ray knows much more about I spent all the time thinking about human rights and how they're suspended. I personally, and I know of other people who, for a very limited short period of time, if it was therapeutic, if it was beneficial, would be willing to have those suspended. This is a personal opinion.
I know it's your experience, yes.
Yeah, it's not just my experience, it's that of others as well. This is what the review found. This is
completely irrelevant to the point I made.
Can you please...
No, I'm not having this. I'm not having this. Because in a week, I could end up back in sections. You wouldn't be, I fucking could be. This isn't a fucking game. There's sod all service. No, stop. No. There are sod all service users here this evening. Yes? All it would take... It's not good enough. It's not good enough. It is not good enough to be disingenuous. No.
We've given you opportunities.
For us to be able to express the complexity, for us to be able to express the
complexity
and the breadth of our experience, it's going to take money. And you've got money, right? Professionals, doctors, researchers, civil servants, they could easily put their hands into their pockets and donate so we can get more service users here, so that we could have democratic service user organisations. And if you're going to waste our time by responding to things that haven't even been said, when we already know that, we just don't have the resources to express the complexity. I feel you're
as a democratic, can we ask other people wanting to ask questions? Could everyone who wants to ask a question please put up their hands? Okay, there are other people who also would like to ask questions. Lady.
Sorry, I sort of stand by the guy there as well, and no disrespect to yourselves on the panel. When I spoke to Simon Wesley and I said about the green paper that was going to be done, and I said of what happened to me, and I was misdiagnosed for 6 years, okay, and I was given multiple of medications for 6 years, okay, labels that you can, and when I say that, my blood's poisoned to the point then I got electric shock treatment. And after the 6 years, this was after the birth of my daughter, okay? And they was told I never had postnatal depression, but no one bothered listening to me. None of the medical staff listened to me, and it still doesn't happen. So today when Claire says, we're going to do this thing, and then you'll make this kind of decision, there will be a clause in that will say, well, because of so-and-so, we can't do that. Now, after 6 years, and I begged and begged and begged, and they told my husband, she's never going to recover. I went into hospital, and I came out suicidal. And what I'm saying is, why is there an epidemic now And this is 20 years, my daughter's 25 this year. This is 20 odd years ago, okay, but it's still happening today. And there aren't the resources. It's not a case of resources. I don't even think some of, no disrespect, psychiatry, like one person, if you put one person in one room and you said to go and see that psychiatrist, they'll all come out with a different label, believe me. And I do believe that when you're not, you know, the high profile, all these, you know, you've got Time to Change, you've got all these high profile places and people that we know in celebrity world that talk about it, and they are fine. We mention anything. I don't like the word mental. At the end of the day, I think the word mental should go, because that is the stigma. And I said this to you earlier, Claire, people mad, mental, naughty, that's what was brought up with it. You mention that in your life that you've ever been, and I voluntarily put myself there, because I went for Stitch. For a year, I was asking, help me, help me, help me. I had a baby, something's gone wrong. It took 6 years for them to diagnose. And even then, I had to get my own notes and then diagnose myself. That shouldn't be the place. I had a maturity issue. But people are losing their life. And I'm sick of it. I'm sick of all the people every day that I look at, oh, this person's committed suicide, that person's committed suicide, that person, they're locked in these units. Locked up, mothers, kids, locked in the units, and no one is giving a damn about it. So we can have sit on the panel, but there's no one going to any of the units. You look at the primary last week that was on TV, and honestly, you're seeing these families, you're seeing these children, and I'm sick of the talk. And like the guy says, action. Well, you need to take some action, and they need to listen to people about what we think. It's not like going, oh yeah, well the panel says this, and the panel says that, and the psychiatrist says this, and most of you know that there's no chemical imbalance, and a lot of psychiatrists know that. But when you're given 18 antipsychotic drugs, multiple sleeping tablets, antidepressants, and then they wonder, oh, but I'm not allowed to say I'm angry. This is why I say I'm angry, I'm aggressive. Because if you say you've had any kind of, and I have not got no mental illness, and I don't believe a lot of people have. I believe a lot of people got emotional issues, or whether it's to do with a physical condition, or whether it's to do with stress-related illness. You need intervention earlier on, and you need them earlier when the children are growing up. And taking away parents with disciplines on them, they wonder why there's these problems. They won't give parents disciplines to look after. So no. So I think people do need to listen to the people. I'm sorry, but it needs to be said.
Carol.
Okay, I have a question relating to something which Ray said about capacity acts. Now, in Northern Ireland, there was a public consultation in 2011 which came out in favour of replacing the mental health order, which was a law then in Northern Ireland, with the Fuse Act. So we no longer have a separate mental health act as a mental capacity act. Now, with return to functional government foundation in Northern Ireland, we might actually see how this works in practice. I'd be interested to know what the panel think of implementing this in other parts of the United Kingdom, and if it was a missed opportunity that this was not done by the Mental Health Act review.
Okay, so the question is about whether the fusion law was...
Right. We vote.
Well, I mean, one, as you know, one point you know, but other people in the room may not know, is that Act isn't in force yet. And I think it's fair to say that it's being watched with some considerable degree of interest / concern to see how it's going to be implemented. Because one thing which is coming out very strongly from everybody is culture, professional cultures. And one fear is that one simply the same thing happens under a different name. So in other words, those people who currently the Mental Health Act is used on, or in Ireland, Northern Ireland Mental Health Order, the Mental Capacity Act Northern Ireland will simply be deployed upon on the basis they don't have capacity. Is that better? Is that worse? I don't know, but it isn't necessarily going to say, well, there's going to be a reduction in the number of detentions. So if that's what people want, you wouldn't necessarily get it. One other thing I would flag up, which explains one of the reasons why the review was cautious, the review didn't recommend, but did say here is a series of steps to think about that you might want to think about before you either introduce a great big dose of capacity into mental health law or you fuse the two, is the risk that capacity is misused. One thing which comes out very strongly, and every single person's personal experience is different, one thing that comes out strongly from some people is a huge fear that what will happen is people will say, you've got capacity, some moral judgment, I don't like what you're doing, go away, you take your own life. Nothing to do with me. Radical disengagement of services on the basis which sounds very nice. That is a very real, genuine issue which has to be grappled with in a way which achieves a consensus. So, what I would say, I'm not speaking on behalf of the review because I can't, but one thing I would flag up that the review was trying to identify was what needs to be thought about in order to try and think whether that is the way to go. Because in one view, it does solve. It says there is one ring to rule them all. You know, you don't have separate standalone legislation. It has a superficial, enormous degree of attraction. But there might well be a serious case of be careful what you wish for. I would also just flag up that if the UN CRPD committee, if you're seeking to achieve compliance with what the committees say, you're not allowed to have that either. Because they do not see mental capacity as a valid dividing line between actions that can be taken in the name of the person and actions which are recognised as being the person's own actions. So there's a big floaty issue, or big overarching issue, but a number of very practical things. Right.
She just not said I wanted to speak.
Never go after a lawyer. It's a bad idea.
I would like us to move closer to that fused stuff. I was reading about it in preparation for this, and I was like, wow, it kind of makes sense. The idea that instead of people making decisions in my best interest when they don't know me and they don't agree with what I think, that they protect my will, you know, what I want to happen, and that there be someone around who's there to stand up for what I want to happen. But the problem, as you said, is this giant load of potential for misuse. In austerity, enough people are being chucked out of services that are already a bit not great, but they're better than nothing sometimes. The government doesn't need extra reasons not to support people. So for that to work, there needs to be this massive culture change where mental health and mental health legislation and this dodgy part of detention is something every single person is concerned about. And I think the failing is on us as a collective society, because this should not happen. And it shouldn't be that people will misuse it, but they will. So how do we actually change that and change ourselves so that we do protect people's rights and are compassionate? I don't know.
Okay, Carol, and then, yes, Dorothy, I see you.
I'm reflecting on a lot of the anger we've heard in the room, and I'm thinking it's not just lack of services, it's the quality of services. And although Larde says services are improving, yes, in many cases they are, and they needed to, when we go back to generations. Still, too many people have those hideous experiences that we've heard Ray talk about, we've heard Ben and other colleagues in the room talking about. And those poor experiences, those traumatising experiences, even Mark said, services aren't kind. That's the fundamental. They should be at least kind. They should at least not do more harm. Too many people not only don't get help, but they get further harmed when they turn to services. I've coined a new phrase, psychiatrigenic. When you're harmed by the services that you turn to, you're already vulnerable, already fragile, already struggling with your mental health, there is nothing like it. It leads you into a cycle where you literally don't know where to turn, where you're made to doubt yourself, and then you doubt the people who would normally help you when you're doubting yourself. There is nothing quite like that cycle. And then it leads to an even bigger disrespect, simply because you're mentally unwell. In the services we care, we have had long discussions about epistemic disrespect, epistemic contempt, where you're not taken seriously, where you're not able to speak out again about what's happening to you, simply because you have a mental health problem. That in itself can be traumatising. For those people who've been traumatised, who've had some sort of abuse, Lade talked about childhood, about adverse childhood events not being taken seriously now, especially for BME communities. What about those adverse mental health service events, and especially adverse mental health act events, when you've been detained and you've been forcibly injected and you've been secluded and all those horrendous things that we hear about still happening? That for somebody who's been traumatised already and abused already, there is literally nothing like it. To be abused then by the people you're turning to for help. And so that's where I think the cycle could be broken. If people's knowledge and autonomy was more respected, if people were thus able to gently speak out and have their views respected, then things would change. It's something we tried very much to do in the Act, certainly in terms of the principles, to try and get more autonomy, to get more respect for the person's knowledge and so on. But it hasn't gone far enough, and whether, if the new, when the government get their act together and the thing takes place, just how much respect will actually come out of that, and whether things will change radically enough remains to be seen. But that, I think, is where things could change. Make services kind, and to do that, allow people to speak out, have themselves respected when they do speak out if things aren't good, and then things will maybe turn around.
Thank you.
I'll respond to that.
Can we just hear Dorothy as well, and then respond to
It'll be very quick. Well said. I agree. And that is why in my bit I mentioned about the principles not just being focused on detention. Actually, these things are not done very well, full stop. And when we think about people who find themselves in contact with the mental health system, especially at the more kind of severe end, even in the community, there's something that's gone on, and more often than not, they've had poor experiences with relationships, and is it too much to ask that we've got caring communities and caring staff? The other thing that I would say is that when we have these discussions, we end up talking about services. We very quickly end up talking about services and a very fixed idea or kind of focus around mental health services. We need to, and it's quite difficult because it gets quite messy, that again, when I was given that question to answer, I didn't actually answer it. Because how can you? Because it requires everybody in society to do something different. And that might sound slightly amorphous. It might sound like something that we can't grab hold of. But it absolutely is. It's a huge task. I would like to see society get kinder. If we could, kind of one thing out of this, if society became kinder, if, we were to be more responsive to the people around us. It seems like it's real far away from somebody being led through the doors of a hospital when they're just being detained. But actually, two are not that different. And one closing point, which I'm sure is going to be very contentious, I would argue that there is no one type of person who gets detained. There are people who have been detained and who entered the mental health system and would find it very difficult to get out. But actually, the reality is, anybody can enter a situation in their life where things slide and they end up being detained. Very, very similar to the idea that there isn't one type of person who gets suicidal. And I think that if we we absolutely need to listen to people around the room that have had those experiences, both service users and carers, but we mustn't create a divide that says it's us versus them. there are lots of people who, whether or not it's willful ignorance or it's just ignorance, they don't know. We have to have compassion for them. And I know that sounds really, really odd, but if we don't, the chances that they're going to do something different are very, very slim.
Thank you. Dorothy.
Okay, first of all, I'd like to say I very strongly agree with the human rights points that various people with lived experience, experience have been raising. I very strongly endorse those. And also, in my view, like a lot of people, we don't think the review has gone anywhere near enough, is nearly fundamental enough. My other concern about it is the contradictions that run through it in human rights terms. On the one hand, there's a principle of autonomy. On the other hand, detention is still recommended if on a reduced scale. On the one hand, there are advanced directives. On the other hand, you have to be assessed as capable first, and we all know the huge problem with capability assessments. And also, why have that two-tier system? Why can't people, those who are assessed as not capable, what about using some of the very effective support mechanisms so people can equally make choices which are accepted? In intersectional terms, I find the review contradictory and discriminatory. I strongly endorse the emphasis on people from BB communities, on people with learning difficulties, the emphasis on asylum seekers and refugees. But what about other people who face intersectional issues? And what about people who face a number of intersectional issues? You may be black, for example, and identify as gay. So, I'm very concerned about the contradiction in the review. I'm very concerned because I still find it discriminatory. And also, where review recommendations are muddled, that in itself runs the risk of even recommendations that are there not being effective.
Thank you. We're going to have to finish soon, getting the signal. So I'd like to thank the panel for their contributions, and I'd also like to thank the audience, and I'd like to thank the people who spoke out. Perhaps I...
Just put your hand in your pocket.
I don't think I personally can change the system particularly, but I take the point that...
You personally, you and others...
Okay, well, thank you. Anyway, thank you all for your contribution, and thank you for coming.